Vanessa Sena, and first question anyone asks is, why is Cena Health with a C, and why is your last name with an S? So my last name is Sena. It's a derivative. I'm Mexican American, and Cena with the C actually means dinner. It's a play on my last name, but to actually be appropriate for what we do, C makes more sense. We are in the food as medicine space, but we're more so in the health technology space, and what we can do with food as medicine and creating better preventative care for patients. So a little bit background, I'm a food systems consultant. During COVID, I worked with a lot of hospitals, Hartford Healthcare, Cena Health, St. Francis, and eventually our state department, in developing food systems to deliver food to outpatients. If you guys remember, during COVID, no one was able to come to the hospital. They were immune compromised. And so hospitals started to team up and say, what can we do to get food to our patients? So we started some grant funding projects with Hartford Healthcare's behavioral health program, 11 hospitals statewide. That was our first big project. We soon started working with Cena Health in clinical trials and feasibility studies to understand how we can create these systems, but how we can actually get some data and some feedback from patients. We started working with the Department of Maternal Fetal Medicine and patients with gestational diabetes, and creating medically tailored meals for these patients. But we soon came to realize that the food wasn't enough. There had to be education, there had to be ongoing support, and so we started to create our clinic. We are the first standalone food as medicine clinic in the country. We partner with hospital systems. We offer registered dietitian and behavioral health counseling on top of just the food delivery. But again, that wasn't enough, because hospitals and clinicians and payers started to say, okay, these programs work, but they're still siloed. So how do we actually build infrastructure that will allow our clinicians to prescribe the food, but then to understand actually if the food is working? Where's the data? Where's the technology? How do we implement all of this in one system? I went back to the drawing board and I found two co-founding engineers who worked already with Accenture, who worked with enterprise systems, who worked with health systems. My CTO, he works with Cincinnati Children's Hospital. He is in bioinformatics. He understands data. He understands health hospital technology and infrastructure. So they started building the technology that now started to implement the data collection and the AI infrastructure that starts helping us understand what's happening to their patients at home while our team is working with the patients, that allows us to triage patients to the right provider. So one huge gap in the system right now is that a patient not only goes to the hospital too late, so we're trying to prevent that, but they also keep going to their GP for things that are not, their clinician doesn't need to work to continuously work with them. An example of that is we're working with the chief of infectious disease on a clinical trial for patients that are HIV positive and food insecure. And what he basically said is, my patients will come to me when there's already a big event. They don't have a GP, they don't have a general practitioner, they don't have anybody that they're going to regularly. So they keep coming back to me. I'm acting as the all-encompassing clinician. And he goes, it's really tough for me to do this. It would be great if a patient was able to be triaged to the right provider. So something that we do is that if a patient is showing, these are high-risk patients, if a patient has uncontrolled diabetes and they're looking, their blood sugar continues to raise and they're not getting any better, we send them to our dietitian. Our dietitian works with them, changes up their meal plan, hospital utilization avoided. Patient is struggling with their mental health or stress. They go to our one of our counselors. They're not going back to the chief of infectious disease. The patient is having a social issue. So maybe their lights got turned off or they don't have transportation to go to the hospital. We reach out to their case manager or their social worker. So that's huge, and that's saving hospitals money and that's saving the payers money. But then it's also continuously caring for a patient while they're at home and under our care. And it's personalized, right? We're working with that patient. We're making sure that they're getting taken care of. The next The next best thing is that we're able to work proactively, and we do that through the AI. So we have a risk stratification. We have scores for patients. If a patient has a social issue plus mental health, I'll give you an example. Patient is HIV positive, they're malnourished, they're not eating, and they're depressed. Well, that score is going to be pretty high, and we're able to stop, get in there and do an intervention right away, and that might take multiple providers. But the goal here is to make sure that patient gets taken care of at home before it becomes a hospital event. Doing that, again, allows us to save the hospital's money, care for that patient faster, and then report back to payers. So far, we've had some really good feedback. Cena Health, again, is our first big project with these HIV positive patients. We are in talks with Cedars-Sinai in Los Angeles, Vanderbilt Health in Nashville. And then we're currently raising as well, and we are in active diligence with some healthcare investors that actually think that this can be big and that we can really make a difference in caring for these types of patients. So I'm here to answer any questions, and I'm here to elaborate even more if you guys would like. But yeah, that's what we're doing. Yes, sir.
So how do you get paid?
Oh, so we have a hybrid model. So because we are a clinic, all of our dietitians, care coordination, and counselors get paid fee for service. So we're actually able to bill insurance. So CPT codes are what they're called on a high level. But basically, like if you were to go into any clinic, they bill insurance. We also negotiate an initial infrastructure fee for the hospital. So in order for them to work with us and to implement our technology and the system in general, we have an implementation fee. And then we work on a shared savings model as well. So it's called value-based care. Basically, the better you work with the patient, the more you're able to save, the more you keep them engaged, you actually get paid for that value from the payer. And then we would negotiate that. So if we're able, an example will be if we're able to save a hospital $10,000 on a patient, we actually get a percentage of that $10,000. Yeah. Yes?
Great presentation. I like the Cena.
Yeah, thank you.
Tell the guy, how lucky are you for that? It sounds like you're an infrastructure organization. Can you expand on what that experience is from the consumer side? So you mentioned payers are involved. Mm-hmm. Can you just talk through person XYZ?
Yeah, the patient journey.
They have Aetna insurance, they work for Pratt & Whitney.
So that normally wouldn't be our typical user, because we do work with high-risk patients that are usually food insecure. So I will give you a user journey that would be best suited for a Cedars-Sinai. So in California, they are an approved Medicaid 1115 waiver recipient, which means patients can actually get food prescribed to them already or get referred to a vendor. What's happening in LA is that there's no way to understand if the patient is actually eating the food, to understand if the patient likes the food, if it's actually helping their, reducing any cost, and if it's, if the hospital's saving money, payers saving money. So Cedars came to us and said, we need a way for that patient to have more than just food delivery, because we don't even know if they're eating it. We don't even know what's going on once we give out that referral. So when a patient gets referred by a case manager at Cedars-Sinai, they come through us, We connect them with the food vendor. Their food vendors are on our platform, so we're able to monitor their performance as well, and their satisfaction scores and things like that. And a patient will meet with our dietitians first. A dietitian will set them up on their account in our system, show them how to make their food order, go through their diet plan, their meal plan. We're getting in health information, so it's something called an ICD-10 code, so it's a diagnosis code from the hospital. They're going to tell us if the patient is morbidly obese. They're going to tell us if there should be food insecure. They're already enrolled in the program. Patient has uncontrolled diabetes and has high blood pressure. So our dietitians understand, okay, they work with that patient, they set up parameters on the system that allows a patient to only order the food that's allowed for them based on their diagnosis codes. And then also their food preferences. So our dietitians will talk with them and say, what type of cuisines do you like? Is there a spice level that you like? What allergies do you have? And then set all of those parameters up in our system. Patient knows when they go on and they order every week that everything that's previewed to them is something that they can actually order. They don't have to think about it, which is great. So patients order every week, and then they meet with our dietitians. Depends on what they're covered for, so usually it's Medicaid, and that might be anywhere from usually every 3 months, 3 to 6 months. But they're working with them, but they're also able to work with our counselors, which is every week. So it doesn't matter what state you're in. For mental health counseling, Medicaid covers every week if you wanted to go, sometimes even more. So if they're continuously needing support, they can continuously work with our counselors as well. We're tracking everything. We're tracking user insights. We're tracking, how the food is measuring up to the clinical aspects. So every time a patient gets lab work done, every time a patient goes into the hospital, we are collecting that information and we're sizing it up against their meal. So if we're seeing their A1C is going down, if we're seeing their blood pressure and their weight is going down, it's a really good sign showing the program works. But what is also important is if that patient stops engaging, we see that they're going into the hospital, their A1C is not improving, their weight is not improving. That's going to be either cause for intervention, or we're going to have to reach out to the patient and see if they don't want to be in the program anymore, and then we don't allocate any funds to that patient anymore. But for the patient, they're continuously getting care, they're continuously getting food that they like, and they're continuously giving us their feedback to help us understand how we can better help them, and then, obviously become better, healthy human beings. Yes?
So, struggling with the question because what you're doing makes sense. Your business model makes sense. You're able to avoid costs to these healthcare centers. You're helping the people. Some of this seems so, for lack of a better word, obviously beneficial. Why? What challenges are you having scaling? What do you need?
Well, I think kind of what I talked about in the beginning. It was, we started with the food systems and the logistics, and then it became, we need to make this clinical, and you need to have education, and you need to do this, and then it became, well, you need infrastructure, and we need technology, and we need integration, and it was just kept more and more and more. And what is happening in this space is that there are solutions, but they're siloed. my team and I figured out that it needs to be all-inclusive. You need to have all of it in order for a hospital system to be comfortable with being able to work with you. We did partner with Cena Health So they're our EHR of choice, and that was very strategic because Athena is a trusted name. They already integrate with every Epic system in the country, and it's easy for us to collect data, clinical data through Athena than having to build our own system and having to try to convince a hospital to work with the no-name provider that, it just didn't make sense. So for us to connect with them was a huge win. I'm seeing a lot of competitors. I don't have a lot of competitors because we're more strategic partners, but I'm seeing some other people in the space building their own systems, and they're going to find it to be really tough if they ever want to integrate and actually become part of the hospital's infrastructure. It's going to be really tough. Yeah. So those are things that are some reasons why it hasn't been done yet. People are choosing solutions that are still siloed and not actually connected and not infrastructure. Yes?
So is the realm that you're addressing Medicaid? That's the realm?
Medicaid, Medicare, and dual eligible. So that's primarily the targets we go for. It's high-risk patients. Reason being is because that's where payers and hospital systems lose the most money on. And it's also, when we hear statistics about, chronic disease and it's a $4 trillion problem, and, if there was only a way to help out these patients that are high risk, if we can at least get a whole handle on what's going on with those patients, it would help everybody. All of our premiums would go, that's at least what they say, what the payers tell us, right? So, for us to target those, it's kind of what you would consider low-hanging fruit. These are the patients that really need help. These are the patients that are asking for help, that they don't have a solution. Everyone's asking for this solution, and no one's been able to provide it. And so that's...
And they would typically go to the hospital, and that's the reason for the cost.
Yeah.
Right? So the hospital is trying to say, let's stop you coming in, take care of you.
Right. Yeah, exactly. Yes.
Thank you, Vanessa. This is great. Just curious if you'd be willing to share with us a little bit about your story and journey and how you got here.
My own personal story. So I'm, again, Mexican-American from Los Angeles, family very much type 2 diabetes ridden, and it's been through both the food that they ate plus alcohol. I'll just be upfront and honest about that. So I did see a lot of my family getting their limbs taken off, being hospitalized, and eventually passing away. Myself, I used to be 250 pounds. I had gastric bypass surgery like almost 20 years ago, 19 years ago, I think. Lost 100 pounds, and I've very much been on my journey. But I also went to culinary school, and my background was in culinary. And when I moved out to Connecticut, it was to partner in a meal prep company. Didn't work out. My partner and I kept butting heads, and so I dissolved the partnership, and I started to get calls from, my first consulting gig was edible arrangements of all places. That was pretty cool. And then that went into CT Pharma and started to build that whole infrastructure for them to understand really what it's like for manufacturing, and I learned how to use not EHRs, I'm so used to saying EHRs, but using their technology and understanding all of that. And then I'm trying to think, shortly after, it was working with Hartford Healthcare. And then as I started working with these programs, just seeing the gaps. Continuously there was a gap here, there was a gap there, there was a gap there. And I kept getting asked, can you do something about this? I eventually had a meeting with the Dr. Prem Kumar, who's the president of primary care at Hartford Hospital. And he said, we want to grow with you, we want to work with you, but you have to develop a sustainable revenue model because COVID's going to leave and we're not going to be able to get grant funding anymore. You got to figure this out. And that's when I was like, well, if I am a clinic, I can get reimbursed. And that's pretty sustainable. It's a headache, but it's sustainable. So that's when I started the clinic. And then again, it's continuously working with these programs. It's continuously working in research, because I never thought I would work in research. You don't go working for a huge chef at a restaurant one day thinking, oh, I'm going to work with hospitals and in research. Like, that's just, it was crazy in the best way. So being able to start partnering in research projects and clinical trials and understanding what is really needed, feasibility studies. I will say our first feasibility study, the gestational diabetes patients, we got 100% retention, 100% satisfaction. Every single patient said that if they ever became diabetic again, they would use our program again, and they would recommend us to their friends if that happened. So that was a huge win, and it tells us we're on the right track. It tells us that we have different customer segments, so it tells us that the hospital systems and the providers themselves love the program, but also that the patients love the program. And so it just kept us going and said, okay, we're on the right track. And now it's led us to where we're at now. And, the goal here is to get our data from the HIV population, understand the technology, get their technology built for a true go-to-market strategy and getting into other markets, and just validating the model so we can take this. We want to build a repeatable, scalable model that takes us into other markets with other hospital systems. And I'll give you HCA in Nashville. We approached them and they said, we don't want pilots, we want programs. If you're going to come to us, have it ready and we'll talk. I got to build that. And so we're doing that right now with UConn.
That's super compelling. Thank you so much.
Thank you.
So are you currently in Connecticut and any other state at this point? Or?
Currently in Connecticut and Connecticut only, talking with Mass General Brigham Health Plan. So that hopefully will come in the works very soon. And then again, Cedars in LA and Vanderbilt in Nashville. And if all of those hit by the end of the year, I won't have a life, but that's okay because it's the life I chose.
So do you see the model having to require you having a physical clinic in each market? Or?
No. The way the business model is set up is that we have to have a physical clinic, at least one, because that's how you get your license. But other than that, you can do everything virtually. So everything through, Athena's virtual, it's all telehealth, and that's how we'll move into other markets.
So for patients with no housing security, are there accessible ways for them to be able to order this, have it picked up somewhere since it can't be sent?
Yep, absolutely. So 2 cool things about how we do things, and it's only because working with these patients, I understood really what could happen. And so we deliver to any standing brick and mortar. So that could be a shelter, it could be a rec center, it could be a place of work, it could be a hotel. Especially when we worked with behavioral health patients, a hotel was pretty common. Even the hospital or nonprofit would pay for the hotel. We would deliver food to the hotel. And then the other really cool thing about the way we work is that a lot of what we can do can be through over the telephone. So we understood, I understood as I started to work with these patients, the lack of technology or the lack of understanding how to use the technology. So a patient doesn't have to have a smartphone and they don't have to have a laptop in order for them to work with us. We can actually work with them over a phone. We can actually work with them on a landline. When we started working with patients that were, or the homebound for the elderly, and that was a state program, we worked with a lot of seniors that didn't have smartphones. So it was how do we do this? How do we still allow them to work in our program and give them access? So they would call in their orders, literally call in and say, what's on the menu this week? And we'd go through what's on the menu. That sounds lovely. Oh no, that doesn't sound good. And they would tell us, and I'm imitating one particular patient that we had, Miss Carol, and she was so blunt and honest, and we would get her order and we would put it in the system for her and make sure that it got sent out to her every week. So Again, through trial, we were able to understand kind of what our patients need and the lack of resources that they have, and we could still work with them. Thank you. Yes.
So I've been curious on how you're thinking about your target market. You mentioned, understanding it's Medicaid, Medicare, dual eligible. There are payers in there. But from a market, you did the gestational diabetes. That's a specific target market.
Mhm.
HIV specific.
Mhm.
You mentioned high risk, which you could have any multiple types, like heart diabetes, each of which has a slightly different need to
Mhm.
some degree.
Yeah.
How are you I'm curious how you're thinking about where to focus because they are so varied. Or maybe
Yeah.
you're like, we're just going after all of them.
Yeah. So the market dictates our flow. So example of that was Chief of Infectious Disease calls us and says we're going to be working with patients with HIV and are food insecure. So what type of food, let's go through dietary guidelines. What type of food are those patients needing to eat? So we work with some local food vendors and we talk to them about what the diet needs to be. They'll work with our dietitians on their menus. Our dietitians are already they already understand what it's like to work with that population, so they're good. And then with gestational diabetes, we do the same thing. So they came to us and they said, we want to go ahead and create this program. Okay, so let's talk about what the dietary guidelines need to be for a patient that has gestational diabetes. Then we go ahead and work with local vendors and we say, can you create meals within these guidelines? You're going to be partnering with UConn, this is the big deal. Again, they work with our dietitians are, they're accustomed to working with patients. In fact, we have dietitians that came from WIC. We have patients that have their own practices as well, working with pregnant people. So we let the market kind of come to us and tell us what they need. With Cedars-Sinai, it was very much they want to work with the patients with diabetes, and I think with Mass General Brigham, it's dual eligible patients, probably with comorbidities. So we'll have to just figure out who we partner with there in Mass. We also partner with national vendors. That's not my priority. I would like to work with local. I like the whole, and like you guys here, I like community helping community. So if I can get local vendors in state to help with those patients, then that's my first choice. And we go through the guidelines and we make sure they work with our dietitians to develop their menus and so on and so forth.
So it sounds like regardless of what the health condition is, there is a pattern of identifying the food. You still have to serve the food, how you get the community. So for you, if someone came to say gestational diabetes, whatever they condition, you will do that up front, diagnoses to figure that out. But the other elements of your organization, there's a pattern there.
Yeah.
So regardless of whatever that condition is.
Correct. Yep.
And are foods delivered once a week or?
Foods are delivered once a week. Yeah. It really depends on the program. That's what we've done in the past. We have a new food vendor, Chrysalis Center. If you guys have heard of Chrysalis, they're located in Hartford. They have a kitchen and they have a food pantry. So they'll be offering, for this HIV population, they'll be offering meals plus pantry items. And they'll be sending, I think, once or twice a week. They're still trying to understand their own logistics. But even if it's twice a week, that's fine.
There's a CRT, Community Renewal Team.
Yeah.
They are small. Nancy Isa runs the nutrition division.
I would love to speak with her.
She has the second largest commercial kitchen in Greater Hartford after the hospital. And they have fleet of trucks, place is massive, and there's I think like 8,000 square feet of
Wow. That is super, super cool. If you do have a connection, I would love that. Yeah, thank you. Hi, yeah.
Hi. Great presentation. I missed a lot of it, but I really love the concept.
Thank you.
For your website, and I think that's a great initiative. My question to you is, when you have so many food vendors, because you obviously want to deliver to so many areas, not just in Connecticut, but maybe all over the US, right? How do you manage QC in these cases.
Yeah.
You know, especially with the food, and since it's a medicine, it's going to patients.
Right.
Right? That makes it very serious business.
Yeah.
So what's your plan for QC, or what are you doing for
Yeah,
QC?
so my background is in food systems. I'm a food systems consultant. And so I teamed up, initially hospital systems and our state came to me to handle all that. So I'm very fluent in how to manage multiple food vendors, how to manage quality, manufacturing, logistics, all of that. Our system, our technology, every food vendor creates accounts on our technology. We're able to monitor them. We see their performance. We track their deliveries, and then satisfaction scores as well. So if a patient is not loving them so much, we need to have a talk and kind of understand why. But yeah, we handle all of that. An example of that is with Cedars-Sinai in Los Angeles, because they already are recipients of the 1115 waiver. They already have, I think, 8 food vendors that they work with. So when we partner with them, we will partner with all their food vendors, get them on our system, and go ahead and start tracking it. Yes. Yes, Mr. Mendoza.
This is such an incredible and supportive program for the community, for the patients. You're creating a lot of reliability when it comes to access to food. Sometimes programs have funding stalls. Have you designed some sort of mechanism to protect those patients so that they can sort of be offloaded instead of cut off?
Yeah. Yes, so I'll give you 2 really cool examples of how we tackled that, because that was also an issue that we had. That was what was happening already, was that we were getting grant funded. Grants are few and far, like they're not coming in anymore. So it's like, okay, how do we build a sustainable model? So 2 ways we went about it. One with the Yukon project is that building the model, proving the outcomes, so collecting the data, giving the data, like actionable data to Yukon, and their goal is for our phase 2 to be incorporated into their 340B budget. That is a budget that comes through for drug savings. So when these Medicaid patients come to Yukon, they have a budget, 340B budget, that's allotted to them through the federal government. It's kind of a subsidy. We would be able to be on that budget as well. So that would create a sustainable way for us to continue working with these patients. And in fact, what Yukon wants to do is say, go into other clinics now, because this is working. This is working. So that's the whole goal with Yukon, and how we can build sustainable flow through their 340B budget. Now with Vanderbilt and Cedars, this is a value-based care project program, which means we go into negotiations, we sign a contract. The first year, phase 1, there's an implementation fee. We set everything up. They're basically, it's a baseline net zero. Like, it's just make sure that we built the thing. And then the second year is in a shared savings model. So proving engagement, reduced utilization, faster bed churn, reducing staff burden. How much did we save the hospital? Okay, we saved the hospital $1 million. We actually participate in some of those shared savings. So we'll get 30 to 40% of those shared savings. And that just keeps going and rolling.
So, I'll probably keep asking questions even though.
It's all good. It's all good. Keep me thinking.
Yeah, no, and you've mentioned this throughout. What would you say are some of the most challenging implementation aspects of your entire solution, from business model to setting up the infrastructure to engaging people behavior? What, from your perspective, are some of the most challenging parts of the implementation thus far?
People, managing people. It's funny, not funny. As we are building out our AI and starting to work with that, my engineers have a joke. They say, if AI doesn't produce what we need, we tell it, and it changes, and it'll produce what we need. You know how difficult it is to work with somebody, a person, and try to, work with them over and over and over again. So I think for the most part, that's probably been our toughest barrier, but not one that I'm not willing to tackle. It's also funny because I tell my own staff, I have to meet with CMOs and providers and CEOs and CFOs and all the big names, but at the end of the day, I'm relying on the cooks, on the drivers to actually get the food prepared properly, packaged properly, delivered properly, and it's just so many people that I have to go through. And you get sometimes, food vendors that don't want the added work. It's really hard, like for farms. When I introduced the food pharmacy at Hartford Hospital, I consulted for that project, and one of the things I had to do was get a collective of farms to come on board and to offer their produce for this food pharmacy. And to me, it sounded like such a great opportunity, but for the farmers, they just saw it as more work. So it was like, how do I relieve their burden as well to get them on board with helping out their community and to do something that might be different? Like getting a hospital contract is probably, again, not something that they ever thought was going to be in their future. But understanding kind of how it can be bigger than what they're thinking and getting them on board. So those are usually the challenges I face. Yeah, I think Danny has one more.
I think you've answered a lot of the questions in the room.
Yeah.
How can the room help you if you haven't already asked?
I love the CRT because, again, food vendors, as we grow, having food vendors that are on board and have the logistics already embedded in what they do is like super huge. It takes a huge burden off of me to partner with bigger names that can handle bigger populations. So I think that would be great. And if anybody else knows people that are in the food as medicine space that would like to be a part of what we're doing, I would definitely love that help in that intro.
So I guess you answered the question, how as a community can we help? So, thank you for a wonderful presentation.
Thank you.
Today.
Yeah.
We have a gift, our Million Cups thermos. Watch that by hand. I don't know why.
Well, I'm not going to wash it by foot.
Well, I don't know. Put it in the dishwasher. I don't know why you can't do that. Anyway. Thank you so much.
Thank you.